Assalamu alaikum wa rahmatullah. A warm morning greeting from the holy city of Mecca to all patient safety professionals who dedicated their time and effort to provide safer diagnostic care to patients and attending today our conference, the third Saudi Patient Safety Center conference. My name is Dr. Ahmed Sheikh. My life mission is to treat hospitals, and I'd like to thank the Saudi Patient Safety Center and the scientific committee for inviting me to be your moderator for session 2 under the title of Creating a Learning Health System for Improving Diagnostic Safety. With 4 distinguished speakers and patient safety leaders, all of them blended clinical and patient safety experiences to add to our knowledge today. Before we start, a quick reminder to use only the live Q&A to post your questions, which we're going to address in the final 10 minutes of this session. My great pleasure to start the session with Dr. Khalid Zahrani, the Deputy Director of Security Force Hospital Mecca, a sub-specialized orthopedic consultant and patient safety advocate. Dr. Khalid, who advanced his medical career in Toronto with an orthopedic fellowship and mixed his clinical knowledge with medical education in patient safety from the University of Toronto and quality management. Dr. Khalid, with a very wide knowledge and experience in patient safety, is a member of the Patient Safety Center Consultancy Board, professional trainer in patient safety with the Saudi Patient Safety Center, chairman of AO Trauma Association Saudi Arabia, and member of the RETTAO Trauma Middle East since 2012. And he is the professional development faculty in Sibahi since 2016. Dr. Khalid will speak for the coming 25 minutes about team steps for diagnostic improvement. Please join me in welcoming Dr. Khalid. Dr. Khalid.
Thank you very much, Ahmed, for this introduction, and I would like to thank the Saudi Patient Safety Center for giving me this opportunity to participate in this third conference of patient safety. Today, I will talk about the diagnostic errors and how can we improve it using specific tools. And my learning objective here today is to define the diagnostic error, and it's important as a patient safety issue. It's a rising problem, and we should think more about it and have tools to address this problem. We also will talk about explaining the impact of provider communication breakdowns on the diagnostic error and describe how can we use TeamStep as a tool to reduce diagnostic errors. We all know from previous presentation by Dr. Salvador that diagnostic harm is an emerging area of concern in healthcare quality and patient safety, and this is very important to provide our patients with a better health and better care. There are few tools currently available to guide healthcare professionals to address this problem and this rising issue, and one of those is TeamStep's framework that will help healthcare providers to address problems related to diagnostic safety events. Let's start with some interesting data from AHRQ, and this will help us to know the magnitude of the problem. HRQ data showed that 1 in 3 patients experience a diagnostic error in firsthand, and this is a quite big number that we should think about it more and reflect about it and consider it a serious problem that we need to address. Of those, 33% of all diagnostic related malpractices or error related mainly to one or more communication breakdown, and this highlights the importance of improving communication efficiency between healthcare providers. From those 33%, we could analyze it more and know the severity, which shows that 69 of those patients have a high severity impact on their healthcare, and this could lead to death in 34%. Looking to the areas where this problem is happening, diagnostic-related communication failure occur across all healthcare settings. It can occur in outpatient, in emergency department or inpatient. This most frequently happen in outpatient in 55%, in emergency department in 23%, and inpatient in 22%. These high significant number of errors have a significant cost and impact on the healthcare system. So looking to the process of the patient journey throughout healthcare facility, the diagnostic error or diagnostic safety event can happen at any phase. It can happen in the ambulatory care as we shown before, in primary care setting, in specialty practice, in day surgeries, and in ambulatory surgery settings. In high complex setting like emergency room or intensive care setting, there is a high risk of diagnostic errors that should be focused and addressed to prevent this from happening. Long-term care facilities is another area that we should think about it that could be a risk for diagnostic error because patient is staying with us for a long time and we might take these kind of cases as easy cases and they need only nursing support, but sometimes those patients might develop and problems that need to be diagnosed properly and diagnostic safety event could happen in that area. So generally speaking, diagnostic safety event can happen in any healthcare setting, and this is very important that all healthcare providers should focus on. Let us take the patient journey. So the patient, when they experience a health problem, what they will do, they will visit an emergency room or outpatient or any healthcare facility seeking help. From there, I'm sorry, the healthcare provider will start to collect some information based on clinical history and physical examination, and we will do for them some diagnostic testing. And sometimes we need to do some referral and consultation to collect all relevant information. This information will be collected by a healthcare provider and it will be interpreted, and from there, it will be reflected and communicated to appropriate specialty. If there is any problem related to this data gathering, this could affect the treatment where the treatment basically based on appropriate information that was collected throughout the patient journey when he started to visit the hospital. So at any phase of this patient journey, we should focus and think that we are gathering appropriate information and we analyze it in proper way and we are communicating this information to appropriate personnel or healthcare provider who will take the decision and start the treatment aiming for a better outcome for our patients. So let's go and know more about the causes, why these diagnostic safety event is happening. Mainly, the problem can start from data gathering because at the initial phase of patient journey, we started to take some information. In a high busy practice or like emergency room or outpatient clinic, sometimes the healthcare provider could gather incomplete data, and incomplete data should lead to incomplete or inappropriate management and diagnosis for our patients. Other reason could be related to deficit. So competency of healthcare provider is very essential and important to reach appropriate diagnosis, and from there we could reach appropriate management. If there is any deficit in the knowledge of the healthcare provider, this might lead to a problem related to the diagnosis, and misdiagnosis could lead to a significant diagnostic safety event. Other cause could be related of clinical reasoning of the information that gathered in the first place. So there must be a good training for all healthcare providers to have a clinical reasoning that will support the diagnosis, and support reaching appropriate diagnosis will help to support reaching appropriate treatment. In some areas, there is another reason like lack of available expertise, and this could lead to a diagnostic failure, and this failure could lead to inappropriate treatment. Communication is an essential element as we shown before, and lack of reliable and timely communication of the test result or finding of the patient could lead to a significant diagnostic failure. Other reason could be related to delay of the management or delay of communicating the result or the data to appropriate team member, and this will lead to a significant safety problem. Lack of communication between healthcare provider and patient, or between the clinician themselves, or between the clinician and the family member, could also lead to a significant problem. So here we highlighted the importance of sharing all information and taking appropriate information from the patient and from patient family. So, what is diagnostic error? It's mainly failure to establish an accurate and timely explanation of the patient health care problem, or it could be related to omission. Sometimes or something left undone or neglected could lead to incomplete assessment, and incomplete assessment definitely will lead to incomplete diagnosis or inappropriate diagnosis that might affect patient. Communicating this information could be another problem. So if you see in all previous slides, we are highlighting the communication issue is an important factor that might affect patient safety and could lead to inappropriate diagnosis. If we look to the diagnostic error by type, it might be missed or wrong or delayed diagnosis. So if we miss to diagnose something, this may be related to competency or inappropriate data gathering from the patient. Wrong diagnosis is another problem that can be affecting our decision to take appropriate treatment, or we might have the information, but there was a delay in diagnosing or delay in delivering this information to appropriate caregiver, and this will lead to a significant problem. For example, recently we are analyzing a case, came to emergency room with a chest pain, and there was a junior staff who was assessing this patient, and this junior staff just put this patient on a bed and asked him to wait while they should or they must take an immediate action. This delay of the patient care lead to a significant problem because the patient was having a major heart attack. So how can we address this problem? Now we know that the diagnostic safety event is common and it's everywhere in the hospital, and it is in all healthcare area might happen there. So one of the tools that I would say that it's very efficient and very helpful is the team steps for diagnostic improvement. This is recently introduces module in team steps, and we all know that team steps is one of the successful tools that help to improve patient quality. So team step is an HRQ product, and it represents team strategies and tools to enhance patient performance and patient care. So basically, Team Steps is an evidence-based teamwork system. So it focused mainly in communication, improvement, and teamwork enhancement systems. It is designed to improve effectiveness, specifically in care quality, patient safety, and efficiency of healthcare. It is practical and adaptable, and you can apply it in all healthcare settings. Why it is important? We all know that even in highly skilled and motivated professionals, there are risk to have some error, and they must focus to improve their performance. And we all know that communication is the leading system-related breakdown that can cause diagnostic errors, and this could cause a harm to the patient. Team steps improve communication and teamwork performance and improve the teamwork skills to help them to improve healthcare provided in the healthcare institute. And we all know that we should enhance the teamwork system across healthcare setting to improve our outcome for our patients. Team Steps is also a comprehensive. It's cover all aspects of healthcare, and it's customizable. You can adjust it and customize it according to your needs, and it's easy to use, and it's publicly available for all healthcare providers. How can we apply Team Steps? Basically, team steps have three phases. So if you want to apply it in your healthcare setting, you should do assessment, and then you should do planning, training, and implementation, and then you have to plan for sustainment. So assessment is a baseline assessment, so you will know the gap, what is the problem, basically, and what you want to address. And from there, you will plan your session and training and implementation. So plan for sustainable effort and train individual in your institute and implement and test the strategies and its effectiveness. For this to be sustainable, you have to integrate all activities into daily practice and monitor the measurements of programs to know more about the outcome and to find if there is an area need to be improved. The main competencies we are addressing in team steps is four competencies to all healthcare provider. It could be very helpful to our healthcare provider in all specialties, in all levels. So it addressed the leadership, situational monitoring, mutual support, and communication. All these competencies will be taught in the course, and it will help to improve the performance of healthcare provider and their attitude and knowledge. And basically, during teaching this type of courses, we use two-way feedback system, and this will help us to learn more about the problem or challenges the healthcare provider facing in their daily practice, and from there we can address it and help them to improve it by improving these four competencies and reflect it on their daily practice. The team steps for diagnostic improvement is recently introduced as a module in team steps, and it helped to improve diagnosis and give the team assessment tool that they can use it for daily practice. It helped them to define their needs and to ask them why is diagnosis is important. And we all know that if we cannot reach appropriate diagnosis, we cannot provide appropriate treatment for our patient. And also, it will highlight the importance and how common is the diagnostic safety event in our daily practice. The module also will help them to practice a reflective practice tool, which is important for them to implement in their daily practice and improve the diagnosis accuracy. Taking all these activities to daily practice, including patients as a member of the team, is important, and addressing all aspects of the diagnosis journey of the patient in the healthcare facility is important. So this module will help to take the patient and the family as a member of the team and address all aspects such as electronic health record, physical examination, imaging reports, consultation, and enhance all these processes to reach appropriate diagnosis, helping the healthcare provider to reach appropriate diagnosis at the end. Teaching the participant in this module on the reflective practice is very essential. We all know that reflection is very powerful learning tool, and teaching people how can they reflect and how can they use this tool to improve their performance is important. Basically, there is a three component of this practice. It starts with asking a question. How do I ask the right question for the right people at the right time to achieve the diagnosis? So this skill will help the healthcare provider to improve asking the appropriate question for the patient and gather appropriate information that will help them to achieve the appropriate diagnosis. Also, it will teach participants how can they actively listen to their patient and gather appropriate information and understand it very well and analyze it very well, aiming to help them for reaching appropriate diagnosis. From these two tools, they can start to act and to reach and achieve appropriate diagnosis based on asking appropriate question and listening to the patient appropriately. The course have 7 modules. Basically, start with the introduction about the diagnostic safety event and how common it is, and then it will help them to structure the team of diagnosis. And after that, there is a specific module about communication and how can we enhance communication between healthcare providers. After that, they will learn more about leadership and how important is the leadership in the team to arrange the team and make the team more efficient. And the other module will focus on situational analysis and situational monitoring of the patient, aiming to achieve appropriate diagnosis. And also, another module is focusing on the teamwork enhancement, which is important to communicate appropriate information and work collaboratively to achieve the appropriate diagnosis. Achieving appropriate diagnosis will help to achieve the appropriate treatment and improve healthcare outcome. The final module will put all these things together and give the participants opportunity to use it in their. The question here, does this work in our daily practice? My answer is yes, because we start to implement these courses in our hospital long time ago, and we basically do analysis of our at that time the situation, and we found that team step is the best tool to address problems related to communication and teamwork enhancement. And from there we train more than 30% of our clinical staff on team steps, and we created and implement lots of improvement projects and create a competition where we find a winner, and all of the participants in this activity will implement all the tools and competencies they learn from the team steps in their daily practice and maintain it for daily work, and at the end they get significant improvement in their daily practice.
Dr. Khalid, 3 minutes.
It's okay. So giving you some data about our performance, we found that in medical imaging, the reporting that exceed 24 hours, we reduced it from 21% to 4%. Medication error was reduced from 25 minutes, 25 events to 3 events per 1,000 patient day. And in PIC, we improved the length of stay from 5.8 days to 2.3, and physician answering call from nurses in more than 10 minutes was improved from 7 per month to 0 per month. In OR, we implemented a pre-op briefing, which was very successful to improve the prophylaxis for antibiotic and DVT to 100%, and there was a significant improvement in outcome because the team will sit in the morning and do a brief about all cases, and they will manage all expected risk at that time. In emergency room, we implemented the team steps tool, and there was a very successful experience. In summary, diagnostic error is a common and often harmful to our patient, and we know that appropriate communication can mitigate diagnostic error, and team step can improve team work and communication and help effective communication to support the diagnosis, aiming to achieve appropriate treatment. 3 overreaching tactic is very important to implement in team steps diagnostic module, which is reflective practice, routine assessment, and action planning. That's all from my side, Ahmed. Thank you very much for listening.
Thank you, Dr. Khalid. As promised, we learned a lot about the role of team steps, and really it was a very good presentation. We learned how it can help the diagnostic improvement, and the new model for the diagnostic safety looks really up and coming. We have questions about the topic we will address in the Q and answer in the questions and answers, so please stay with us. Our next speaker is Mr. Luqman Zaki. the Quality Improvement and Patient Safety Department Manager at Dr. Sulaiman Al Habib's hospital. Mr. Luqman is an MBA holder with a nursing background who sharpened his quality skills as a CPHQ, ISQA Fellow, Certified Six Sigma Black Belt, Certified KPI Professional, and Risk Analyst and Manager. He has been working in the quality domain since almost more than 10 years. And in the last 3 years, he is the Quality Improvement and Patient Safety Manager at Dr. Sulaiman Al Habib Olaya Medical Complex. Mr. Luqman will speak for the coming 15 minutes about reporting diagnostic safety events. Please join me in welcoming Mr. Luqman. Mr. Luqman.
Assalamu alaikum. Good morning, all. First, I would like to thank you, Dr. Ahmed, for your introduction. I'd like also to thank Saudi Patient Safety Center for arranging and facilitating this conference, and for sure for having me in this presentation. I'll share my screen with you. Got just a moment. Yes. Okay. Now, today my topic will be reporting diagnostic safety event, and we will be highlighting the question that has been asked more frequently to the quality staff on why to bother ourselves in reporting diagnostic safety event. Now, through my presentation, I'll be giving an overview, an introduction, and also I'll be providing a statistics on why to bother ourselves in reporting diagnostic issue. And then we'll go in a definition to define what is the errors, and then after that we will highlight the improvement strategies that has been introduced by WR and general rules for the incidents reporting system, or the OVR system that we all know about, and at the end how just culture implementation will promote your OVR system. Now, before going in my presentation, I would kindly ask this question for all audience, and I would kindly ask you, Dr. Ahmed, if you can help me in encouraging participating the audience for this question. The question is, do you think that having more reported incident in a month will reflect a safer environment in your hospital, or having less incident reporting rate by, let's say, 20% is more safer? Again, we will go with our presentation, and at the end we will be answering this question. So the question is purely about number of reported incidents. Do you think that increasing number of reported incidents will reflect a safer environment, or less is reflecting so? Now, sure.
And please, for our participants, if you can post your answer in the discussion forum. Proceed, Mr. Luqman.
So, as an introduction for my presentation, I'll be start with to ERA as a human, the first concept that we are reading whenever we are having any risk management activity, reading any article related to this risk management approach or domain. And actually it was introduced in 1999 by the Institute of Medicine, where they connect to ERA as a human to having building a safer healthcare system. However, in the publication and reading the report does not indicate or does not give us as a human or as a healthcare worker an excuse to do mistake. However, it highlights 7 main domains that is by ensuring implementation, by default you will be having for sure a better patient safety outcome. The first concept that has been introduced in this publication was that errors are costly, and it is really costly in terms of losing the trust of the patient. Trust of the patient is the main concern really whenever we are having an error. Another approach in this publication was that more commonly errors occurs because of having faulty system. Yes, we agree that we don't want to do harm, or we don't want to harm patient. However, having a faulty system will by default ensure or will end by having more and more incidents. The other concept they introduce here, that we in healthcare setting are decade behind other industries in implementing patient safety concept. And they also highlighted that voluntary system will enrich your mandatory reporting system by data in which you will prioritize and do action accordingly. Another issue was you are in need to develop a standard of care. For sure, you will be having a patient safety or better safety outcome. And at the end, they highlighted two main themes. The first is medication safety, and last but not the least is having leadership commitment is crucial, and for sure crucial in promoting the patient safety. Now, going to the other question, why to bother ourselves and why patient safety matter? Again, Institute of Medicine, they estimate in 1999 that 44 to 80 to 98,000 Americans died each year because of medical error. Medical errors are so breathtakingly common that the admonition to report everything is silly. Now, here after this, they introduced the concept of blame-free culture, where they introduce the need to increase the number of reported incidents. And that was due to medical errors. They indicated that it could affect around 7 million globally, or 7 million patients globally. Now, the impact of patient safety, as you all know, it harms everybody. It harms the patient. It harms the provider themselves, the healthcare worker. It harms the institution that you are working on from financial perspective, from regularity concern, institutional impact related to reputation, and public also relation and impact. Now, why, and going in this slide, and to answer why to bother ourselves again, in the 2019, WHO has been introduced this publication where they indicated that the adverse event following hospitalization is the 14th leading cause of death and injury globally. 10% of the hospitalized patient will by default have an adverse event. 15% of the cost of the expenditure are directly because of the adverse event. 18 in the Eastern Mediterranean region are having an adverse event, out of which 83% are preventable. They also highlight that the most common type of errors, as indicated in the graph, is due to therapeutic, and the second is in diagnostic errors. This has been highlighted before with the previous speaker. We need to straighten our scope here into the diagnostic errors. As indicated here by AHRQ in 2021 in June, they indicated that 1 in each 3 patients will suffer from diagnostic error. 57 of this is happening in the ambulatory, and 69 of them is high risk that could lead to have sentinel event. So why patient safety matters? Again, the patient safety is the responsibility of all healthcare workers. However, healthcare leaders have a unique responsibility for ensuring that all patients receive patient-centered, safe, efficient, and equitable and timely care. Now, going to the improvement strategy, in the same publication in 2019 by the WHO Eastern Mediterranean Regional Office, they introduced the new patient safety friendly hospital initiative, where they identify 5 key strategies to improve patient safety, starting from early engagement of leadership to ensure their commitment and to have a clear policies and guidelines. Also, having competent and compassionate healthcare provider will for sure enhance the patient outcome. Engaging patients and family and early engagement of patient will help to enhance the outcome. Having a useful data in order to prioritize and in order to correct accordingly. Now, in the same publication, they introduce 5 stages in order to ensure patient safety-friendly hospital initiative, where we are in need to implement those 5 steps, and they define for us what action we are in need to have in each step. In the first step, they call it initiating phase. We are in need to ensure leadership commitment and to assign patient safety advocate. And we need to raise the awareness bar in this regard. Now, in the second stage, which is preparing, in the preparing phase, all are in need to have a committee in the institution that is caring about patient safety. We need to build staff capacity and the standard and agree on a realistic time frame for action plan. In the assessing phase here, they need to conduct a gap analysis where you need to go with the standard and to define where is the area you need to improve in your institute. Ensure availability of required document is needed here and ask for external evaluation. And here I could highlight that we need to set up a national committee for oversight and continuous improvement, where we need really here to have a national level, at a national level, patient safety committee that could involve all sectors. At the end here, in this stage, they recommend having a use of scorecard. In the next stage, which is improving, we need to identify the gaps in patient safety, and we need to set the priorities and to start with the most critical standard to have or to implement. The next, in the sustaining phase, we are in need to communicate the progress to the team, reward good performance, and celebrate achievement. Now, going to the definition. Sorry?
3 minutes.
Okay. Going to the definition is, what is the diagnostic safety event? It is identified as per AHRQ as any type of healthcare related error, mistake, or incidents, regardless of whether or not it results in patient harm. The reporting system that we are having, and it is well known as OVR system or incident reporting system, the aim of having this system is not to collect data. The aim is to set our priority to identify the area of gaps and to prevent reoccurrence of any incident. Now, for the main category of reporting, as well known for all, anonymous category, and we have confidential reporting category and open category. In the anonymous category, we don't ask for the identity of the reporter. And although this have a great impact increasing the number of reported incidents, however, it prevents necessary follow-up. In the confidential report, the identity of the reporter is well known, but it is hidden from the authority, and such systems tend to capture more useful data. I assume that most of the systems that we are introducing currently in the healthcare sector is confidential reporting system rather than anonymous, because the identity of the reporter could be known for the quality department, however, it is not known to the implicated department. Open reporting, all people, everyone is known here. However, it is having a poor track because of publication. People tend to blame, so they are not recommending having this approach. Now, for general rules in reporting any incident, safety event report is an essential component of any health care system.
وتقري الكونفرزيشن لان لسه بيواجه. Excuse me. Sorry for this disturbance, Mr. Luqman.
Okay. Organization culture play a vital role in enriching and encouraging staff to report, and having psychological safety by implementing trust culture will ensure for sure having more incident reports. Now, for society to improve diagnosis in medicine, they indicate that in the early stage of implementation, it is important to educate, inform, and to get staff involved. Lack of psychological safety inhibit staff from reporting incident. It is also important to move into solution. We don't need to spend more than 6 months in planning the systems. Implementation of Just Culture. Just Culture has been introduced again by AHRQ and adopted by Saudi Patient Safety Center. This is the QR code that has been shared from Saudi Patient Safety Center, and they define Just Culture as a culture in which frontline personnel are comfortable disclosing errors, including their own, while they maintain a level of accountability. So going back to the question that we had in the first slide of our presentation on which scenario are safer, whether having more increased rate of incident report or a reduction of 20%. May I ask you, Dr. Ahmed, if there is an answer about this question?
It wasn't easy to collect as it was in the chat, but most of the answers are going with the increase.
Increasing. Yeah, actually, I predicted this answer that all will indicate that increasing incident reporting will reflect more safety culture, will for sure indicate that there is an area to improve. However, some others could say that reduction of incident reporting indicate an efficient action plan we adopted in the previous months, so it was reduced. So just an answer for this question, the numbers is not matter. The numbers is not reflecting whether you are having safer. Yes, we are in need to encourage having more reports. However, having increased does not indicate that we are having a safer environment in our institution. We need to change the focus from the number on reported incident into system level changes. What is the changes we had because of the reported incidents? So this is our focus. So numbers is not reflecting the safety that you are having. So as a conclusion in my presentation, it is well known in the quality improvement that they say if you need to manage, you need to measure. Here we could say that you can't fix unless you know about it. So you need to encourage reporting. The aim of having a reporting system is not only to collect data, it is to set priority and prevent reoccurrence of any reported incident. No matter what is the number of reported incidents that you are having, most importantly, what changes you made because of the reports. You need to calculate your near miss rate. Near miss rate as a good indication for your just culture or your culture or culture of safety within your institution. You need to have the percentage on periodically basis and act accordingly. The less confidential report you have is the best culture of safety. If staff still have a fear to report and they tend to use confidential reporting or anonymous reporting, still your just culture need to be questioned. And at the end of my presentation, it is really crucial and it is important to involve leadership. Without leadership support, we cannot promote patient safety. Dr. Mahmoud, I wish that my presentation was of value for you and the audience.
Thank you so much, Mr. Luqman. It was really great and magnificent when you highlighted the 5 key strategies and the 5 stages for a patient safety-friendly hospital. We totally agree with you on the call for the National Committee on Just Culture and the involvement of the top management. Kindly stay with us for the Q&A session. I hope that the 2,300 plus participants are enjoying the sessions. Our next expert will be Dr. Aisha Saghir, a consultant family and home health care physician. She's the leader of the Ministry of Health post-COVID-19 project, Choosing Wisely, the topic that she's going to highlight today, and the clinical advisor for the Assistant Deputy Minister for Health for Hospital Service Ministry of Health, in addition to her role as clinical associate professor in Princess Noura bint Abdurrahman University. Dr. Aisha is the head of the National Home Health Care Committee, Saudi Health, and the council chairman of Saudi Scientific Home Healthcare Society Board, Riyadh, Saudi Arabia. With such an impressive expertise, Dr. Aisha will speak for the coming 25 minutes about choosing wisely and overdiagnosis. Kindly join me in welcoming Dr. Aisha. Doctor.
Assalamu alaikum wa rahmatullah. Thanks for the Saudi Patient Safety Center and the Scientific Committee of the Third Patient Safety Conference for having me in today and for covering this important part, which is the diagnostic safety. What I'm going to talk about today is Saudi choosing wisely. That will help in avoiding the overdiagnosis. To start with, nothing to disclose in respect to this presentation. And I would like just to remind everyone that the Hippocratic oath that we will keep them from harm. And this is all the healthcare providers, especially the physician. We have this in the back of our mind all the time. And this is very important. This is the content of my that I will be covering the recognized harm associated with overuse, areas of overuse, and what is the opportunities for improvement, define the Choosing Wisely campaign, and a success story from Saudi Choosing Wisely, and where next in the future. To start with, just I will talk about two patient stories. This is Sarah. She's 27-year-old female. She has frequent headache for the past month. Her history is remarkable for migraine that she had once or twice per year. A neurological examination is normal, but Sarah is thinking that she's having a brain tumor and she's insisting to have a CT scan. On the other hand, this is Khalid. He's 35-year-old male. He has frequent low back pain for the past week. His history is remarkable for muscle pain. The neurological examination is normal. He is thinking about multiple sclerosis as his friend was diagnosed to have, and he insists to have MRI. These are two real stories from our daily work in the practice. Do we need to do this? And do we need to request these radiological things? Is there any harm that could happen from having a CT for the patient? So we need to think about whatever neurological or radiological test that we request for the patient. And it has been shown by evidence that there is a harm, radiation exposure is high for the patient. It's very clear to see here that whatever this is an X-ray, a normal X-ray, and just you can see how much exposure to patient is given. And when you go further for CT, and the highest of this, when we expose the patient to CT for abdominal CT or CT spine, the highest exposure of the patient for this radiation is here. Just the X-ray, as we see it as a simple thing, it gives the patient exposure to harm. And when we go to CT abdomen or CT head, it is more 100 times higher the risk. It has been shown, this is one of the studies, this patient is 29 years old, he has an MRI done, and it shows that he has herniation, which is dislocated here. See the other MRI which was done, this is resolved completely. Nothing was done for this patient, just he was labeled to have a herniation. Unfortunately, nothing was done during the 6 months. It resolved by itself. So what we have here is radiation exposure and now labeling the patient. Labeling the patient with a condition lead to increase focus of minor back symptoms, avoid the normal work and avoid the exercise and even going to his daily life. On the other hand, this is incidentalomas, which is findings that are unrelated to the clinical application, and it is discovered incidentally. This is very common, and this is one of the things they call it vomit. It's victim of modern imaging technique. This is an article which has been published about this, and these are the patients who are exposed and overdiagnosis done for them and expose them to radiation. Are we willing to address the problem? We need to. This is the new Millennium Physician Chart. It shows that we need, while we're meeting the need of individual patient, we need to think about cost effectiveness of the management, especially with limited resources, and we need to appropriately allocate the resources which we have, and not only avoiding the harm, but also we need to think about resources that it's limited and it's used inappropriately, and this is coming because of overdiagnosis. Diving into the overuse in the hospitals, when you go there, and this is what we did actually, we think about the value of care. What is the value of care? Value of care simply is that we have the quality over the cost. And if we could improve the quality by all domains of quality, or reduce the cost, which could be direct or indirect, this will improve the value of care based on the patient optimal outcome that we look for. How to implement or how to improve the value of care, and what is the relation between this improvement of value of care and overdiagnosis with choosing wisely, and what is choosing wisely is an international initiative that aims to promote the conversation between clinician and patient to choose the appropriate care. At the same time, choosing wisely will help to improve the health outcome, avoid unnecessarily harm and intervention, reduce the cost. The prime objective is to encourage the conversation between patient and physician, and it's supposed to be depend on the best available evidence and avoid undergoing unnecessarily test, treatment, or procedure that the patient don't do. Choosing wisely challenge the ideas of more is better, and also challenge we can does not always mean that we should. I can order a CT, but do I need to do it? I can request an antibiotic, but do I need to do it? And so on and so forth. Choosing wisely is an initiative started in the United States, 2012. The American Board of Internal Medicine started. Then it spread all over the world, choosing wisely Canada, choosing wisely Brazil, choosing wisely Australia, Japan, UK, and Switzerland. Now we have Saudi choosing wisely. This Saudi choosing wisely has started recently in 2020. It is the main principles that of choosing wisely that's supposed to be physician-led, because the physicians are the one who requested whatever diagnostic or therapeutic management plan for the patient. It needs to be a patient-centered. Multidisciplinary team should be avoided in this, and it should be evidence-based, depending on the best available evidence, and we need to have transparent. We need to be transparent, and even when we have an overdiagnosis, this needs to be mentioned and released. As I said, choosing wisely starts with evidence-based list produced by each specialty and society. Each society is eliminate or listed the common choosing test or treatment they believe that this is an area of overuse or misuse. This is an example, 15 things physician and patient should question. This was from the American Academy of Family Physician, and one of them is about the imaging flow back pain. Don't image within 6 weeks without red flags. Another thing from the patient side, 5 things to ask physicians need to, or patients need to ask physicians before they get any task, treatment, or procedure. Do I really need it? What are the risks and side effects? Are there a simpler or safer one? What happens if I do nothing, and how much it will cost? Why we are talking about this now? What we think? What we did we did a current assessment, and this was done when we start the initiative in 2020. More than 600 MOH physicians. For them, it was shown very clearly that 82% never heard about the choosing wisely. More than 40% of the physicians who replied, they feel that they are not responsible or they uncomfortable talking to patient about avoiding unnecessarily test. And more than a quarter of the physicians, they consider unnecessary test and procedure as not a problem at all for them. It was shown that to have the priority list, most common overuse by physician was very clear in the antibiotic prescription that it's prescribed unnecessarily. ordering a diagnostic lab, especially in the ICU or before op procedures, baseline laboratory tests, that is unnecessarily, and the ordering a CT or an X-ray for the patient that the patient doesn't need in the OPD and the ER mainly. And it was shown that the main reason for ordering unnecessary test or procedure in about half of the physicians, they said that they want to keep the patient satisfied and on patient request. In other quarter, the physicians want to feel safe and do a safe practice, and on other hand, following the hospital standard that ask them to do unnecessarily things. And these are alarming signs that we got. So we started the Choosing Wisely program. This is enabled by Adapt Health in collaboration with the health holding company. The program focuses on improving the quality and safety of the care and increasing the value of care and reducing the waste and doing implemented by the best practice guidelines in the pharmacy, radiology, and lab. The key activities that done in Choosing Wisely, we start with assessment. Whatever initiative started under the umbrella of Choosing Wisely, need a pre-implementation assessment to know the gap and to start with the priority of the area. Then we go by recommendation, the best and the evidence-based recommendation to be implemented to avoid this overuse and unnecessary procedure. Then we have an extensive training and awareness for all the stakeholders in implementing this. Then we monitor to see the improvement. Started with having the recommendation from the Saudi societies under the umbrella of Saudi Health Specialty, and we had till now we received more than 25 recommendations, and we'll have more that's in the website. This is an example from the Saudi Society of Emergency Medicine, and in the same time when they release the recommendation and educational and paid material in Arabic is released, and this is to go on away how to measure before and after and what's the KPI we measure it. This is the way which we have the recommendation, and it's available on the website. Choosing Wisely program focusing both patient and physician. It will be implemented in all regions. This is one of the examples, the success stories that we have, and this was implemented in Hafr al-Batin in 2020, in which that Hafr al-Batin, they discovered that they have an area in which the ER, they has a lot of tests related to creatinine kinase, ordering a CT scan that's not needing, and prescribing antibiotic and routinely based for acute, mild, or moderate sinusitis. When they collected the data that showed there is an overuse in these things, before they expand and duplicate this Choosing Wisely, they would like to have is it effective or not. And this study was done there in Hafr al-Batin to know the prevalence of using these tests in the emergency department and how it changed after the implementation of Choosing Wisely. This was a study in which we had pre and post design. The population was for all emergency visitors, in which they had requested these three things: the antibiotic or CT, brain, as the first line, and we followed them after. Pre-implementation group was done in October 2019, and then after implementing Choosing Wisely in February 2020, we look for this. During this, we had extensive intervention in which we had an extensive awareness for all the staff in the hospital. The recommendation was selected, given to everyone. Staff and patient were educated, extensive awareness and education program. We encouraged the patient, and we developed an app for the patient for adapting this Choosing Wisely. So we go into this cycle. We promote and educate, promote, and then partner with the societies that release this, and we measure the outcome. So we compare before and after using a very clear statistical way. This is the departmental form for choosing wisely that has been used. This was to increase the community awareness, and this was available as a poster in all the hospital about the choosing wisely. Everyone was trained with the choosing wisely and what these recommendations they need to use in all the related parts, the pharmacy, the radiology, the radiologist, the ER physician, and we had an extensive, so all of them, they are holding a badge that we are choosing wisely part. And an app has been released, and this app for the patients, so we educate them what is the advantage and disadvantage. These are the results before pre-intervention, and you can see very clearly there is a significant difference about the order of this test, that it's the CKMB for the patient before the implementation and after the implementation. For brain CT scan, the percentage has been decreased very clearly, and this is only 1 month difference. And we see that it shows that there is a difference of ordering the test. And the same thing that was done for the brain CT result, that pre and post test. On the other hand, the proportion of the patient encountered with amoxicillin that was prescribed amoxicillin sulfonic acid, how much the patient they received, and post intervention decreased. It was very clear that there was a significant reduction in unnecessary use for the CKMB brain CT scan or antibiotic based on this data. This hasn't been implemented in the system, and it shows a great difference. This is an example on a success story related to choosing wisely. What is next? We would continue to create an awareness for both patient and physician, provide support for all the champions that's now available all over the kingdom. We would measure the impact before and after and continue measuring this. So, to take home message, 5 things physician and patient should question. Don't order investigation that will not change the management plan. Don't repeat lab investigation on a clinically stable patient. Don't order an IV. Pre-op option is appropriate. Don't order non-urgent investigation or procedure that will delay discharge. Don't order invasive study if less invasive are available and safe for the patient. Choosing wisely will as be a part of choosing wisely. Don't provide care with evidence shows is not effective. Decisions are made collaboratively with the patient. We need to give each patient the care that they need, but also we need to consider what they don't need and avoid care that can cause harm for them. It's time to change. They're ready for change. Be part of Saudi choosing wisely. Just we have in the website, just you can click join and see more information on Saudi wisely choosing wisely campaign. Thank you.
Thank you so much, Dr. Aisha. You have chosen wisely the topic and influenced us to choose wisely through a very promising project. And the study, I believe the study made it very clear for us that we are expecting a lot from this project. Please stay with us for the question and answer session just after the coming session by Dr. Mishari Abdul Latif, the Medical Affairs Manager of Becton and Dickinson, BD. Dr. Mishari develops and leads cross-sector collaborations to address Saudi unmet health needs by partnering with local agencies, governments, and non-governmental organizations. He works to address specific health goals, which include improving, strengthening clinical and laboratory practices, addressing infectious and non-communicable diseases, combating in antimicrobial resistance, and improving safety for health workers and patients. Dr. Mishari holds a PhD in microbiology and immunology and master in microbiology. In the coming 15 minutes, he will address how improving laboratory testing process for safer diagnosis. Then we will go directly to your questions in the live Q&A. Kindly join me in welcoming Dr. Mishari. Dr. Mishari.
Uh, Thank you, Dr. Ahmed, and thank you all who participated and assisted or helped in make this event happen. Since I have 15 minutes, I will slightly rush, but I'll focus on specific points regarding improving laboratory testing process. So overall, I will go over the incident pyramid theories. There's two theories we will talk about. At the same time, we will go over the needs to improve testing process, and we will have some stories regarding the diagnostic error cases that happens in US, in China, and other countries as well. Then how can we improve? And at the end, at the same time, we will take how many steps really can assist in improving laboratory testing process, focusing mainly at the end on laboratory automation and really how this has increased improvement in laboratory processing regarding the last 10 years. So in 19 in 1931, uh, Heinrich came up with a theory that says out of 300 near misses accidents, we will have 30 minor accidents, and out of this 30, we will have one serious accident. And he specified regarding this theory with three things. The first one is 88% of accidents are caused by unsafe acts. And what he means by unsafe acts, it's basically saying that the the staff or the in this case lab technicians, they're not following SOPs, they're not following the orders of the lab directors, and this is the 88% of the mistakes or the accidents. Then he mentioned that 20% due to unsafe conditions. And basically, with the unsafe conditions, if you think about it, is when you have a car that doesn't break, it used to be brake, then it does not break. Okay, that's unsafe conditions. We keep this in mind in the laboratory. It's the same side when you have too much machines in one side that can cause an accident to the staff or to the samples and so on. Then the last one is 2% due to act of nature. Well, he's in this way, he's emphasizing in others that not really focused on the unsafe conditions and unsafe acts by the staff. And acts of natural, basically, there is a caused due to natural itself. Okay. So, and this is like really low, 2%. So really we need to focus on the 88%, which is the staff not following the protocols, that following SOPs or the orders of the lab directors or supervisors. Then Frank really focused more in 1961 on this theory, and he said no, out of 300,000 unsafe acts, there will be 600 near misses, and out of the 600, we'll have 30 minor accidents, leading to 10 major accidents, and unfortunately, these 10 major accidents lead to one fatality. So really looking at these three theories, and we keep in mind we are talking about laboratory at the same time. So he's saying basically out of 300,000 unsafe acts, that means the staff not following orders, which will lead to one fatality. Well, in 2018, when we looked at Marshall's paper, he literally talked about two theories, and he said these 3 or 4 limits. First one is a decrease in a small accident doesn't mean that there are no major accidents, okay? But at the same time, he's emphasizing if there is a decrease in small accidents, there will be decrease in major, but that doesn't mean no accidents. So we have to keep this in mind. At the same time, statistics vary from one side to another, and that's very known from, by default, that's really known. And the third is the occurrence of a small accident is an important indicator for studying the safety performance. And this has been used lately, especially with CDC, WHO, to really look at the small accidents as an indicator of the performance, especially with Sabahi, as Dr. Khalid mentioned, and others. Really, these small accidents, really the indicators of the lab performance safety. Finally, is the focus is limited to unsafe behaviors only. So really unsafe behaviors by the staff, which is the main focus because it's 88% as mentioned before. So the summary of the theories and the limitations, humans are the cause of the problems, and basically they're giving it to the manager is responsible for preventing accident from happening. So good luck the lab directors with saving human errors. So really when we look at the laboratory accidents, is it really important to focus on it? Is it really something that we need to look at? And Dr. Khalid really mentioned on Luqman, they have two sites, and one of them said it's the 14th number of causing of death based on WHO as the medication errors. And we look at this number, we think about it, really it makes sense because 70% of today medical decisions depends on the laboratory tests. And that's leading to that, big numbers. And according to the CDC as well, 40,000 to 80,000 deaths occur every year due to that something that we can prevent due to diagnostic errors. Could be due to label error, due to using the wrong samples, and so on. So let's look at the diagnosis error cases, and there is four stories or four lessons that I will mention briefly. So the first one is lesson from laboratory in Pennsylvania, basically that lead to 2 deaths due to overdose of warfarin. So let's look at the story, what happens. So in June, they received a new BT. If you know, the BT is responsible for the warfarin doses, and it's really known in the lab, of course. So when they received the BT, they didn't change the calculations in the lab, and this led to the wrong or incorrect INR, leading to falsely low INR. Okay, so that happens in June. So from June 4th to July 25th, so they're talking about 6 weeks, there is 2,146 reports were correct with BT, but incorrect with INR. That leads the doctor to give, some of them, of course, lead to give more overdose of warfarin, unfortunately leading to deaths. So basically, received the new reagent and calculation not implemented based on the SOPs. Second case, or the second lesson we learned from China, basically they showed the diagnosis error in fatal medical malpractice cases in Shanghai. They showed from 1990 to 2015, there is 649 people unfortunately died due to diagnostic errors. So we're talking about an average of 15 people dying each year due to diagnostic errors in this hospital only. And these, with these numbers, they confirm these are the confirmed diagnostic errors. Of course, there is errors not confirmed, there is errors not investigated, there is unfortunately not reported fatalities looking at the diagnosis or investigating not happened even. And we look at the several hospitals in the US, this is the lesson, our third lesson. We look at several hospitals. This is done by Dr. Phillips and Barker, and they looked at when do we have a high fatality rate in medication errors. That's including diagnostic errors as well in the study. And they looked at this and they found that in July we have a high number, and their estimation due to the new staff coming in the hospital, medical residents, lab staff, and so on. And really the sad thing here is where is the human resource and the manager role to make sure that the new staff joining the hospital really can decrease that number if they have been trained, if they have been shadowed, and so on. Okay, so the lesson number 4 is from Utah and California, that's in the US hospitals. They show that a delay of diagnosis can lead to death. Okay, so and if you look at the y-axis, we have donor A. He has given the platelets to one of the patients, which is the first patient at the top. Make sure look at the blue dots. Each blue dot referring to 6 hours. And if you notice, the death happened on day 9th, where the detection of the sepsis has been on day 3rd. Unfortunately, the bacteria grow as a Clostridium on the after like 2 hours after the patient death. Same case happens in patient number 2, where death happens. Unfortunately, a culture has been grown with the Clostridium after 5 hours. California case, death happens after the 3 hours. A gram stain showed the Klebsiella pneumonia and grown as well in the platelets. So basically, what I want to show here, several hours can play a role in saving patients. Okay, so how can we really increase the turnaround time as well? So we're not really increasing only the efficiency, we're also increasing the turnaround time, and I will take that as the 6 slides. So these problems comes to the lab director or the managers as well, who are responsible for preventing accidents from happening. How can we do this? First, as an easy way to do it, there's 8 steps. I will go through them briefly. The first one, go digital. Of course, you're saving your time, you're saving your staff time with the digitals that going with the papers, looking where are they, and so on. Then focus on management, and this is the case when it happens in when we see the spike with medical errors in July. And really, if you have really good staff, and you focus also on the management quality, making sure they have been shadowed, make sure they have been trained, make sure also they have been trained on all devices that need to be trained on. These really can increase the efficiency in the lab. Third, invest in quality equipment. What I mean here, we can see that nowadays we have the car with the green. That means it saves a lot of gas. And the car B, as an example, with the G, that really lists efficiency with the gas saving. And unfortunately, with the time, we know that the you will pay it with, as you spend with the gas as well. So you will pay it later on, if you think about it, and you have less efficient device at the same time. So really, if you think about the quality of laboratory, really, it can help if you choose a device that has high efficiency and at the same time high quality in the machine itself. The fourth one, of course, keep the equipment maintained. This is very known in the laboratory, so we're not focusing on this really. Fifth, stay organized. Keep your lab organized, especially with the phlebotomists who want to draw blood. If they are organized, they can draw a blood in 2 minutes instead of 5 minutes if they have to look at the tubes, needles, and so on. So keeping the lab organized really increases the efficiency. Document the information, and that can help with the samples tracking. You can see the patient's record if he need to increase the dose or decrease the dose, and so on, if you pair with the physician as well. Then seven,
Dr. Bushiri, 3 minutes.
Okay, thank you. Evaluate the process. So all this process has to be evaluated by the medical laboratory medical manager. The last one is lab automation, and this is really major thing because with efficiency increase, it has been a major role. So with the laboratory automation in microbiology, which I'll be focusing on due to my focus area. Really, if you look at this paper, it shows that samples as blood, urine, and wound, and so on. In 2013, they used a manual process. In 2016, they used the automation, fully automated lab, and they decreased the hours from 2013 to 2016 in each sample. You can see 19 hours for the blood, and for the overall is 13 hours. And that can save indirect cost that comes to the bed when the patient stay in the bed. That costs like each day 4,000 and so on. So it pays off from indirect cost. Then if you look at the lab automation itself, how much can save the staff time, you can see that with the automation itself, it can save more time for the staff than the manual. At the same time, you have, in this case, you can decrease the staff in your lab as well. At the same, and this is one of the interesting studies that in Saudi happens when they implemented lab automations in their sites. They say they did it in microbiology, hematology, cytology, and biochemistry. And by 2 years, they saved 0.3 million by not doing a repeat test and decreasing the volume of the machine requires to do the test as well. And if you can see, the microbiology has the highest number regarding that 2 million. So really it pays off if you have a good device that can save your time and of course your money as well. So the advantages, I will not go over all of them, but I will pick some. Of course, decrease human errors, increase the quality, improve the turnaround time, as we saw with the previous study, by 13 hours and so on. And of course, it pays off with the lower cost if it has long-term, in this case, 5 years or 10 years and so on. The disadvantages, if you use the lab automation for short time, will cost you very high, less than 5 years, mostly will not pay off. Space requirement, personnel, and of course, increased risk of downtime. And if the automation has been shut down, really you need to deal with a good company that can cover you when the automation has been shut down. And this is why we need to emphasize on and really focus on which company that can provide you that disadvantage to be an advantage. And the disadvantage at one more point is you have to decrease the staff in your site, which is a disadvantage for the lab director. But if you think about it for the budget, it's an advantage. So in the summary, we have shown that 70% of today's medical decision depend on laboratory. And I have shown also 8 steps that can improve the laboratory testing process as well. And that's what I have so far. So thank you, Ahmed, and thank you all the team has been involved in this conference.
Thank you so much. Thank you, Dr. Mishari, and I'd like to thank all the speakers for their great presentations, Dr. Khalid, Mr. Luqman, Dr. Aisha, and Dr. Mishari. And I'd like to invite all of you to the main stage in order to start our Q&A. Actually, we have lots of questions. I did my best to summarize it. Okay, so we will have 1 or 2 questions for each speaker. If you please can highlight it in less than 2 minutes each. I'll start with Dr. Khalid Zahrani for the team steps. Dr. Khalid, can you please share with us the best process for reporting of critical test results and the right way of communication with stakeholders? The role of team steps to enhance communication between the stakeholders.
So thank you, Ahmed, for the question. You are asking about how to report panic results, or
yes, how? For example, the question is highlighting the panic results and how team steps can improve the communication between the team in this term.
Okay, excellent. So let's take it from the higher level. The panic results, whether from the lab or radiology or from any other area, it should be mastered by policy and procedures in all institutions. This is in the first place. So the people will be trained based on that. Okay, team steps have tools to improve communication between the team member and how can they utilize appropriate communication channels to report this kind of finding. So the training for people in the team steps will focus basically on what is the current practice in the institution. So in the first, from the higher level should manage this by controlling it with policy and procedures and like workflow that will help to report this kind of finding. According to that, the team step will help the participants in the course to enhance the team communication and how can they implement what's being reported and what is the appropriate channel of communication. So team steps will focus on the team management and communication skills to enhance implementing this kind of policy and procedures, aiming to deliver these messages to the caregiver in appropriate time.
Thank you, Dr. Khalid. So, another elaborated question on this, what is the duration for the training of team steps in order to train the team?
Okay, team steps have many modules, and according to the customization in the institution, the training time will be decided. So basically, the full course will take about 3 days, and there is extended modules can take sometimes to 4 to 5 days. So according to the selected modules, what you will train, what is the aim, based on the assessment in the first place, and based on the planning and implementation process. After that, you can decide how to do this and implement this course. It will take from 2 to 4 days at the most.
Thank you so much, Dr. Khalid. Can we move to Mr. Luqman for a question actually that was repeated in several statements? How can we manage the staff who frequently having the same non-conformance? They mean that even after training and explaining the process, they show to repeat the error every time. How can you implement the no blame culture or the just culture here in this context?
No, actually, thank you. First of all, Dr. Ahmed. Here we need to refer to the just culture recommendation. Now, whenever there is any deviation from standard that has through the system from staff, you need to ask several questions through just culture. You will go with the matrix itself. You will ask the first question. You will be asking, was there any intention behind this gap or this deviation from standard? So if staff is intentionally having this, while you provided the staff coaching, while you consult the staff, you provided them with all needed competencies. So it is negligence issue. Now you need to refer it to a developmental plan for the staff. If the staff is still repetitively doing same and it is for sure impacting the patient safety, at that stage, for sure corrective action shall be considered, because negligence, intentional negligence from staff will by sure impact the patient safety. At this stage, we need to correct. And this is actually based on the just culture recommendation, where you will segregate whether it is a human error or it is because of reckless behavior, they call it. If it is reckless behavior, for sure, correction plan should be implemented.
Thank you so much. So another interesting question, which is, so how can we enhance the reporting? So it's a matter of how do you catch the error through the reporting. So how can we enhance the level in terms of number and in terms of quality of reporting itself?
It relies actually on early engagement of staff. Many fancy, let's say, very comprehensive systems of OVRs has been adopted while it was not communicated from the early stage with the frontliners who will utilize this. The crucial point here, and really the point that you need to focus, especially in early stage of planning, is the involvement of staff. Involvement of staff include what is the benefit of having such reporting system. If a staff really didn't realize that I reported incident and I didn't have a feedback at the end and corrective action has been developed, staff will not repeat again. The first reported incident really from the staff is the first experience the staff is having with you. So if you were not able to meet his expectation, don't expect from him to report again. So again and again, please educate staff, give him a feedback, keep him involved in each step of the reported incident, where It shall be started with reported incident. The incident will be approved by you after reviewing. As a quality staff need to be involved in this step. Then you will send it to the implicated department that made this gap or deviation from standard, and the feedback of the implicated department need to be also shared with the reporter. So if reporter felt that really his input is of value for the institution, believe me, he will report again and again.
Thank you so much. Totally agree with you.
Thank you.
Let's move to Dr. Aisha, and actually lots of questions regarding the choosing wisely. One question is regarding the education. So the question is arguing that choosing wisely need a wise preparation of the society to accept the fact that the limited imaging and investigation does not mean less care. So how can we overcome this barrier? Dr. Aisha? Okay, so I prefer to go to the next speaker until the issue can be solved. Dr. Mishari, thank you so much for the presentation. Touched very important points regarding the lab. The question here from Hillary: has the application of clinical situation of the patient in interpretation of lab results any role in limiting patient hazard from lab error?
Well, if you're talking about if it's processed manually or it automatedly, because that varies.
If you can address both, actually, because the first advice that you highlighted was to go for automation, but what if the automation is still under processing?
Okay, well, if you're repeating the question again, because it's really
Okay, the question is talking about the clinical situation of the patient, the application of the patient clinical situation. They mean the clinical information, the patient-related clinical information in the interpretation of the lab result. Will this add value in limiting the hazard from lab results errors?
Of course, the interpretation is, we call it as post-analytical phase, okay, and not really related. It can play with the automation role, but really depends on the quality of the supervisor and the lab director as well. So yes, of course, it has played a major role. If it's not interpreted correctly, it can lead to death, as we saw with several cases that we have shown as well. Yes.
Thank you so much. So I have one question that I can expand the scope. It was to all of you, if you wish. Then we will go for just 1 minute each. If you can elaborate on, we have Dr. Aisha back. Dr. Aisha.
Yes, hi. Do you hear me?
Yes, we can hear you very well. So one question to you regarding the education, the role of education of the patients, because they argue that choosing wisely need wise preparation of the society to accept the fact that limited imaging and investigation does not mean less care. How can we overcome this barrier?
This is a culture, and I know this is one of the barriers, and this is a main barrier all over the world. Choosing wisely, when it's implemented, you need a lot of awareness, and it mainly depends on conversation between physician and patients while doing the management plan, whatever is it, ordering test results or radiological or prescribing a medication. And we, as a physicians, we are not used to have a lot of conversation with the patient, and a lot of awareness needs to be done in this aspect for both, actually, for physicians and patients, and the media need to support us in this by increasing the awareness everywhere, inside the hospitals, outside the hospitals, and the OBDs and the primary care. And I agree totally that changing this need to change in the culture, but On the other hand, it has been shown by study when you have enough conversation with your patients and enough explanation, and you show the benefit and the harm, it can make a difference. But this need consistently and persistent and high awareness campaign that need to be done at all level, and the physicians need to share to lead this change, because they are the one who are requesting or ordering or prescribing things that is unnecessary.
Thank you so much. One final question to Dr. Aisha. Having well-informed physicians in medical insurance departments and insurance companies can enhance the application of the Choose Wisely program through evidence-based guidelines. How do you agree with this, the role of insurance to reduce the harm through choosing wisely?
This need to be balanced well, because having the recommendation and the best practice evidence and implemented in reality is one of the cornerstones of the choosing wisely. But we need to individualize this. Sometimes need to be individualized according to the patients. Definitely, it will help in reducing the harm, especially when it's depending on the best practice. But need a discussion also on the other hand. To make sure that we are doing the right decision to the right patient at the right time, and following the real recommendation, because sometimes there is a red flag. If it's missed, you will miss the whole thing and the diagnosis. For having definitely a protocol or a guidelines or the recommendation implemented in the insurance will help in reducing, but we need to be also balanced and be careful on implementing this.
Totally agree with you, and this is what we're going to experience in the coming years in the transformation to the insurance model in the health transformation program. Thank you so much. I've really enjoyed your sessions, all of you, Dr. Khalid, Mr. Luqman, Dr. Aisha, and Dr. Mishari. It was my pleasure and honor to be the moderator of this session for today. And lucky me, I'm going to again to rejoin the audience, the 2,500 audience in the coming keynote session. We will have a break for 45 minutes. And again, we will be back at 1 p.m., 1:15. We'll be waiting for you. Dr. Jeffrey Sullivan Harmon will be with us in the coming keynote session. Thank you so much. Thank you all, and see you after the break. Thank you for our speakers and moderators.
Bye. See you.
Thank you.